my pleasure to present Jeptha Curtis, who will give a talk today and an update on stroke prevention and AFib and left atrial appendage closure devices.
Thanks, Rob. So I'm going to talk a little bit about stroke prevention, but mainly focusing on left atrial appendage occlusion and its as it's relevant to clinical practice for cardiology, structural, and electrophysiologists. And let's see if we can make this work. So some disclosures, I run the Data Analytics Center for the ACC. I received salary support from them as Chief Science Advisor and hold stock in Medtronic. So for atrial fibrillation, just as way of background, the projections are that the prevalence of atrial fibrillation in the United States will only increase over time. So looking at what Alan Go projected in 1995, when at that point there were about 2 million Americans living with atrial fibrillation, we're now out towards 2020, 2025. So, and I think we've held up that there are at least 3 million people with atrial fibrillation in the United States. And this remains a significant source of morbidity and mortality in the United States. If anything, I think the numbers are going to start to accelerate in terms of prevalence of atrial fibrillation due to the increasing use of wearable monitors and our increased ability to detect atrial fibrillation in shorter doses and patients who may be asymptomatic. Early on, or for a long time now, it's been recognized that atrial fibrillation is an independent risk factor for stroke. If you go back to the Framingham study cohorts, the risk of patients with atrial fibrillation had a 5 times greater risk of thromboembolic stroke than patients without atrial fibrillation. And if you compare it to the risk associated with hypertension or coronary heart disease, it's certainly one of the strongest and comparable only to a history of congestive heart failure. For purposes of the rationale for left atrial appendage occlusion or closure, there have been a number of studies that have identified that among patients with non-valvular atrial fibrillation, that thrombus identified in the left atrium is predominantly found in the left atrial appendage. So it's not a global risk of embolism forming, but it's rather localized geographically due to the pectinates and the great sluggish flow and great surface area of the left atrial appendage. And this forms the rationale for, like I said, left atrial appendage closure. Talked about the increasing prevalence of disease, talked about the risk of stroke associated with it. I think compared to other forms of stroke, those associated with atrial fibrillation or suspected to be of embolic origin, they tend to be larger strokes with a greater residual disability, which I think is important to think about as we think about how to prevent strokes in this population. Within patients with atrial fibrillation, as you all know well, we commonly use the CHADS-2-VASc score to risk stratify patients into high and low risk. And really, it boils down to that this is a simplistic risk score, but it works really well, such that you can stratify patients from 0 to 9 on the score, and the associated annual risk of stroke varies from 0, although it's probably not exactly 0, but as high as 15%. If you have every risk factor possible. So this is used in clinical practice and is embedded into the coverage decision for the Watchman device. Anticoagulation guidelines really haven't changed all that much. I think I confirmed this morning, but I think the ones that are still relevant are the 2014 ACC/HA HRS guidelines that recommend anticoagulation with either warfarin or DOAC, but preferably DOAC for all patients with a CHADS-2-VASc score of greater or equal to 2. And the European guidelines are a little bit more stringent, where they recommend oral anticoagulation for anyone with a CHADS-2-VASc score of greater or equal to 1. For warfarin, which was the mainstay of therapy for stroke reduction, it is a little bit problematic due to the narrow therapeutic window. On this graph, you see on the left side, in the dark line, the risk of ischemic stroke, and on the dotted line, you see the risk of intracranial bleeding, which is a proxy for all types of bleeding associated with warfarin therapy. And there is that sweet spot, that window between 2 and 3, which informs our recommendation of INR guidelines for this population. DOACs really have been a game changer over the last decade and a half, where it is very clear that they are superior to warfarin in virtually every endpoint of reduced bleeding risk and increased efficacy. Meta-analyses have confirmed this, that really DOACs should be the preferred anticoagulate strategy for most patients. The problem with anticoagulation in general, though, is the risk of bleeding. Who are on blood thinners are obviously at higher risk of a major bleeding event and intracranial hemorrhage specifically. Again, similar to what we do with the CHADS-2 VAS score, we can risk stratify patients, and we have a simple risk score, the HAS-BLED score that we use, and again is embedded into clinical guidelines as well as the coverage decision for Watchman, where we use the HAS-BLED score, and increasing HAS-BLED scores are associated with increasing risk of major bleeding. I will say it doesn't stratify as nicely as the CHADS-2 VAS score, but it does a pretty good job. It also doesn't, however, capture all the risk factors for bleeding and the things that we worry about when we're prescribing our patients anticoagulation. So it's useful, but I wouldn't say it's comprehensive. When you look at patients with atrial fibrillation, in this case, patients who are being considered for with atrial fibrillation who are being considered for an ablation, a large number of them have contraindications to being on oral anticoagulant therapy. And this work from, I think, John Pacini down at Duke, it's demonstrated the distribution of those contraindications. And some of them are not true contraindications, but relative reflect preference. So about a quarter have a history of bleeding, a quarter have just refusal or patient preference to not be on anticoagulation. About 20% have high risk of bleeding or high risk of falls. And those are really the most common reasons that patients aren't on anticoagulation. This is older data from the Pinnacle Registry that established practice patterns in the outpatient setting for patients with atrial fibrillation. And it was pretty disturbing if you think about it. And I don't think it's changed, even though this is published in 2016. So it's one of these stacked bar graphs. At the top, you have patients who are not on any anticoagulation therapy, and the light brown is aspirin only. And so what you see here is on the x-axis, the CHADS-2 VAS score ranging from 0 to 9, and the range of anticoagulation therapies or strategies employed for each point on the CHADS-2 VAS score. What I look at when I see this is that there are a lot of patients, at least 20%, 25% of patients who are on nothing. And then you see another 25 to 30% of patients who are on aspirin alone. And that's fine if your CHADS-2 VAS score is 0 or maybe even 1. But as you get into CHADS-2 VAS scores where patients really should be on oral anticoagulation, you're seeing that about 50% of them are on nothing or aspirin only. And that's really problematic. That's a big opportunity for stroke prevention that we're missing. Furthermore, it's not a matter of getting people on oral anticoagulation. It's about maintaining them on it. And this slide looks like pretty much every drug prevalence or persistence slide that I've ever seen published, such that at least 20% of patients who are prescribed a DOAC are not taking it at about 2 years out, or 30% even. And it's even worse for warfarin. So about 50% of patients will not be taking warfarin 2 years out after the initial prescription. So it's a problem that we're not getting these medicines to patients, and it's a problem that the patients aren't actually taking the medications once they're prescribed it. So what are the alternatives to oral anticoagulation? So there's aspirin, and as you said, as I noted before, that is commonly used in this population. It is clearly inferior to Coumadin. It's clearly inferior to DOACs, in particular Apixaban, among patients who couldn't be on Coumadin for some reason. And it's really just a placebo in my mind. It really has very little efficacy for stroke prevention and atrial fibrillation. The DAPT approach has been used as well, but again, is inferior to Coumadin and maybe a little bit better than aspirin alone, but not really that useful. And then you have left atrial appendage closure, and that can be either surgical, which most commonly is performed at the time of concomitant CABG or valve surgery, but it can also be performed as a thoracoscopic procedure with a atrial clip device. And then you have percutaneous left atrial appendage occlusion with either endovascular or epicardial approaches. So just pausing on surgical clipping, there really are, as far as I know, no randomized trials of surgical clipping at the time of a concomitant procedure. Dan Friedman, who previously was here before escaping back to Duke, published this in JAMA, where he did observational STS data with, I believe, CMS claims data, and identified that patients who had atrial fibrillation and a history of atrial fibrillation and underwent surgery, those who had concomitant or the surgical left atrial appendage closure did better in terms of risk of thromboembolism, risk of all-cause mortality, and the composite endpoint, with really no differences in hemorrhagic stroke. So I'd say overall suggestive of a big win that we probably should be using this more routinely in our surgical populations. And interestingly, I have no idea what our practice is within the Yale New Haven Health System as to how frequently our physicians or surgical colleagues are taking advantage of this. There is also emerging data that suggest that you can predict who's going to have atrial fibrillation after stroke, after surgery, and that in this case, prophylactic surgical closure of the left atrial appendage may also be warranted. But I'm going to spend most of the talk from this point forward talking about the Watchman device, which is pictured both ex vivo and in this animation in its preferred place within the left atrial appendage. And it's a pretty cool device. It's PTFE fabric sewn onto a nitinol frame. The engineering is pretty remarkable. Comes in a few different sizes. It's a self-expanding device, and it basically acts as sitting within the left atrial appendage, ideally at the level of the circumflex, and excluding all the pectinated areas of the left atrial appendage from the circulation. It by itself does not provide protection against stroke. It doesn't prevent blood from getting into the left atrial appendage. It depends on, like many of our endovascular therapies, the endothelialization of the device, which takes time. So we think that it takes about 45 days for complete scar formation over the surface of the device. And that scar actually creates the barrier that prevents blood from getting into the left atrial appendage. And the theory here is that if the vast majority of thromboembolic strokes from atrial fibrillation originate with a clot in the left atrial appendage, that if you prevent blood flow in the appendage, clots can't form. If clots can't form, they can't break off and cause strokes. So it's a fairly simple thought process that justifies it. Whether or not it works is another question. However, what you can see in both pig and human examples is that there is or can be a smooth scar formed over the device that seemingly would provide protection. So how does it work? Hopefully this animation will work with my kind of low bandwidth for my Wi-Fi, but we'll see. Let me know if it's not showing. But basically we access the right femoral vein. We use a 16 French Cook sheath to get the transeptal sheath into position. We then perform a transeptal puncture in a routine fashion, usually aiming for inferior and posterior. We then have a wire that allows us to deliver the access sheath, and then we navigate into the left atrial appendage with a pigtail catheter, advance the access sheath into the appendage, and deploy the Watchman device. This shows an ideal position, again, at the level of the circumflex and well opposed. Over time, the scar will form, and you'll have protection against stroke. So that's the theory. When we're deploying these devices, we're really looking for a few things to say that this is going to work and that it should stay in. So these devices are all retrievable up until the final release. And we oftentimes try different access catheters and different angles, and even repeat the transeptal or different size devices to try to optimize the fit of the device within the appendage. But at the end of it, we're looking at the position. Is it at the right position? Is it covering all the pectinates and trabeculations within the appendage? Is it going to reduce the risk of stroke from that? The anchorage, are the barbs suitably engaged into the wall of the left atrial appendage? Is the device stable? Is it going to stay in place? Is the size correct? So the fixation depends both on the barbs that are part of the device, as well as the external radial pressure exerted by the nitinol on the left atrial appendage. And so with the old device, we shot for 8 to 20% compression. With the new device, we're shooting for between 10 and 30%, but ideally 20% compression. And finally, we're looking at the seal. Is the device firmly embedded into the wall of the appendage, and is there no or minimal leak? So for that, we're looking at we will accept leaks 5, and in most cases will achieve 0 leak at the end of the procedure. So in terms of position, as I mentioned before, we really want it at the level of the circumflex and not too far out. We don't want a shoulder, which will predispose potentially to embolization. So we really want it to fit snugly into the left atrial appendage. For size, again, we're using compression tables to aim for 10 to 30%. For seal, we're using our TE Doppler as well as angiography to demonstrate that there's no flow around the device. Certainly there will be flow through the surface of the device that we oftentimes can see by angiography, but as long as there's no flow around, we think that will eventually, that will seal up over time. So what does this look like in terms of actual clinical practice? So hopefully these films will work, and let me know if they don't. But on the left, you see a typical left atrial appendage. We've got a little bit of fluid, pericardial fluid at baseline. You see the circumflex, which is one of our targets. You see the pectinates within the left atrial appendage. And our goal then is to do the transeptal puncture and navigate with the pigtail catheter the access sheath into the left atrium or left atrial appendage. We then remove the pigtail and we get ready to deploy the device. When we deploy it, you see on the right side, we're looking at sort of how it's fitting within the left atrial appendage. And if it's too deep, in which case we may not be covering the lobes that we need to, or if it's too superficial, in which case we either can have leaks around the bottom of the fabric, or we can be at increased risk of embolization. Neither of those things is good. So we look at the position. We also do an angiogram. Sorry, the angiogram is done beforehand to look at the shape. We'll do another angiogram afterwards. On the left screen here, you see after the device is deployed within the left atrial appendage, we're looking for seal. So we look at it in 4 or 5 different angles to make sure we really fully evaluated the full device. And in this case, with the Doppler, you're not seeing any leak around the device. Now, there will still be flow behind it, at least for the first 45 days, but as I mentioned before, should be gone by 45. And then we do another angiogram to confirm that there's no leak, again, around the device. So in this case, we're injecting dye through the tip of the access catheter. It's hitting the surface of the device, and you can see some of it is slowly pushing through. That's the late filling that you're seeing, but we're not seeing any filling from around the device, either on the superior or inferior surface. In this case, we're also looking at the length of the shoulder. So where does the shoulder of the device sit relative to the mitral side of the left atrial appendage? If it's too far out, again, that's concern for risk of embolization. In this case, it looks pretty well situated. So for post-procedure management of these patients, they tend to be low-risk procedures, and I'll come through this in a little bit. But by Medicare requirements, at least for the first 5 years of this device's history, all patients were being admitted to the hospital overnight. However, with COVID, Medicare seemingly has relaxed that requirement. So same-day discharge is increasingly being used. We've done it a few times for our first cases of the day and have had good results with that. So I think this will indeed become much more of an outpatient procedure over time. We like to resume the Coumadin or DOAC therapy and like to start it that night and continue it for 6 weeks after the procedure. We obtain a follow-up transesophageal echocardiogram at 45 days, but can use a CTA scan as an alternative. And what you're looking for that is that the device is still there, that it's well positioned, and that there's no leak around the device. And the thought is that if those criteria are met, that you can actually stop the anticoagulation at that time and switch to DAPT, which per the study protocols was used for 4.5 months followed by aspirin monotherapy. There are some questions still as to whether or not that 45 days is actually sufficient, or if it would be better in patients who can take oral anticoagulation longer to extend that out to 3 months or so. The rationale is that in cohorts of clinical practice where they have done late imaging, so they've gotten either a transesophageal echocardiogram or a CTA at 3 months or 4 months after device implantation, that they have seen not insubstantial rates of device-related thrombus outside of the device that potentially could be a source for thromboembolism. They have not seen or described a high risk of stroke among patients with device-related thrombus, but certainly it is a concern. So it's, I think the more recent clinical studies have mandated anticoagulation for 3 months after the device implant. However, at the same time, those same trials are allowing DAPT therapy for instead of oral anticoagulation from the day of discharge. So I'm not sure how that's going to play out, but there are multiple options available. So what's shifting gears? What's the clinical evidence for the effectiveness of the Watchman device? So it's interesting. The FDA approval process for this was, in fact, very prolonged, much longer than Boston Scientific had expected or planned for in their economic analysis. But it goes back to at this point, there are still, as far as I know, only 2 randomized trials that have been completed comparing oral anticoagulant therapy, specifically with warfarin, to the Watchman device for stroke prevention. So the first was PROTECT AF, which was conducted in the early 2000s and enrolled and randomized 707 patients in a 2-to-1 ratio of Watchman versus warfarin with standard INR targets. They had 4-year follow-up with a fair number of patient years that were identified. There were 2 continued access protocols after the initial PROTECT AF registry, and both of those were used for sort of following the clinical outcomes in non-selected or non-trial-based clinical populations. And then we had the PREVAIL, which was a second randomized trial mandated after the FDA did not approve the Watchman device after PROTECT AF because of concerns of complications. So they forced them to do a similar, albeit smaller, randomized trial, specifically looking at the complication rates or powered for looking at complication rates. And I'll show you the results in a minute. But the interesting thing was PROTECT AF demonstrated effectiveness, but raised a question of safety. Ischemic stroke in the arm compared with the warfarin group. So what are the success rates? So you can see that there definitely was a little bit of a learning curve. So from the initial clinical experience, the first and then and those studies, that there was a lower success rate of about 90%, but certainly throughout the randomized trials, the continued access protocols, as well as in the Boston Scientific's LAO cohort of patients, about 95–98% success rate. So it's a high success rate defined as successful implantation and release of the device. However, the complication rates are not insubstantial, okay? Particularly from, on the left side of the screen here, you're seeing the PROTECT AF complication rates. So at that point, you had a almost 4.5% risk of pericardial effusion resulting in tamponade requiring some form of intervention. You also had a 1% risk of procedure-related stroke and a almost 0.5% risk of device embolization. So you can see that while, and I'll show you the effectiveness of it, while it was effective, this safety signal did catch appropriately the FDA's eyes. So then in the PREVAIL study, the second randomized trial, the complication rate among those randomized to the Watchman device were much better, reflecting enhanced technique and specifically probably the use of the pigtail catheter to atraumatically engage the left atrial appendage, whereas before in PROTECT AF, they were directly accessing the appendage with the access sheath. So this greatly reduced the risk of pericardial effusion requiring intervention from 4% down below 2%. The risk of embolization was still reasonably high, about 0.5%, but the risk of para-procedure related stroke was much lower at less than 0.5%. And then in clinical practice, both in European as well as the United States experiences, we were seeing much lower rates of all of these outcomes. Specifically in the United States, a 1% risk of pericardial effusion requiring intervention with very low risks of embolization and stroke. In terms of effectiveness of the device, I alluded to this before, but overall for the PROTECT AF and PREVAIL, if you combine the two studies, which I think is probably appropriate for a meta-analysis, in this case, you see that it met its primary outcome of being not inferior to warfarin monotherapy amongst patients who could take long-term warfarin therapy. So when you looked at the subgroups of the individual components, there was a slightly increased risk of ischemic stroke among those patients randomized to Watchman compared with warfarin. There was a lower risk of hemorrhagic stroke, and there was a lower risk, albeit slightly inexplicable, of a combined risk of cardiovascular or unexplained death. When you look at bleeding outcomes, not unexpectedly, given that most of these patients were able to come off of Coumadin, that the risk of major not bleeding, not procedurally related, was lower for those patients randomized to Watchman compared with warfarin. When you look at observational approaches to defining the effectiveness of this device, one of the things you can do is look at the stroke rate out to 5 years and compare it to what the estimated stroke would be given patients' underlying CHADS-2 VAS scores. And what you see is that it's comparable to the stroke prevention rate predicted by being on anticoagulation. I see there's a chat. So Brian Cammy, does our experience mirror the post-approval complication rate? I would say yes, Brian. Certainly we have had complications, and that's not unexpected given doing invasive procedures, but we can be happy to share the NCDR reports with you, but our overall complication rate is in line with or superior to that of national experience. So what do we see in terms of the risk of bleeding over time? What we see is if you do a landmark, so it's a little complex doing this in observational data because obviously for a period of time, these patients are still taking blood thinners. And so again, in the clinical trials, they kind of did a double landmark analysis. And what they found was that there really was no difference or in fact, higher risk of bleeding associated with those randomized or with those patients treated with a Watchman device in the first 6 months, which corresponds to the time period that they were on either anticoagulant or DAPT. But then after 6 months, the curves really start to change, such that patients who were on, who received the Watchman device had a much lower risk of bleeding compared with those patients who've been, I think in this case, randomized to the warfarin. Okay, so I mentioned that this was a really long, tortured process to approval for the Watchman device. From the sort of initial pilots and non-randomized feasibility safety studies conducted all the way in 2002. After the initial PROTECT study was initiated, and then the final results came in, it went to FDA approval and was denied. That required the performance of the PREVAIL randomized comparison, and then eventually led to a split decision within the FDA, but approval as of March of 2015 for this device in clinical practice in the United States. In the meantime, Europeans with a slightly different regulatory environment were able to get this device up and running in registries, non-randomized real-world cohorts as early as I think 2011. So again, our processes are a little bit slower, and that has positives and negatives, but in this case was unexpected. So soon after that, as part of the regulatory approval of the device, it required a registry to be formed, and that's the NCDR Left Atrial Appendage Occlusion Registry, which has been up and running since December of 2015. We've had the privilege of being the data analytics center for that registry since that time. So as I mentioned, FDA approved the device in 2015, and then CMS released its coverage determination in early 2016. And what it noted, and these still apply to a large extent, is that they will cover the left atrial appendage closure only when specific criteria are met. And so there's some of these are patient requirements, so that eligible patients have to have a CHA2DS2-VASc score of at least 2, or a greater than 3 if it's a woman. That patients have to be able to take short-term anticoagulant. In this case, they specified warfarin, but that's been modified to include DOACs as well. However, they need to be unable or have a very strong rationale as to why they can't take DOACs or warfarin over the long term. And then there needs to be documented evidence of a formal shared decision interaction between a patient and an independent non-interventional physician using an oral OAC evidence-based decision tool, which basically was a problem because when they released this decision, there were in fact no evidence-based decision tools available. So it created a little bit of a problem. There are a number of shared decision tools that are available now. We use the one developed in conjunction with the University of Colorado, and the ACC actually maintains a website that allows patients and physicians or clinicians to go through that shared decision-making tool to confirm that left atrial appendage occlusion is the right decision for that individual. So those were the patient requirements. And then there were a number of hospital and operator requirements. So number one, hospitals performing this device had to have their data submitted to a prospective national registry. That's the LAAO registry. And then for operator requirements, either the IC, EP, or cardiovascular surgeon had to have a minimum number of transeptal punctures through an intact septum, which was not a problem for electrophysiologists, but had been or has been a barrier for interventional cardiologists, at least those not doing a lot of mitral eclipse. And they have to maintain a certain volume of transeptal punctures over a 2-year period. As far as I know, no one's ever looked at the compliance with this requirement, but certainly I think within our system, we all meet those criteria at this point. And then there's a facility requirement similar to what they had for TAVR, that the procedure be performed at a hospital with an established structural heart disease and or electrophysiology program. Okay, so what are the clinical indications for LAAO closure? A lot of these are fairly straightforward. They're thrombocytopenia, recurrent bleeding, and for the ones that we see most commonly, GI bleeding or history of GI bleeding, urinary or GU bleeding or pulmonary hemorrhage. We see a fair amount of epistaxis actually is an indication for it. I never realized just how common that was until we started seeing these patients. There is, again, prior history of IC hemorrhage, the requirement of long-term dual anticoagulant therapy, dual antiplatelet therapy. Recurrent falls is a major referral group for us, patients with poor compliance or intolerance to anticoagulant therapy. And this is really the last two are the softest of these, patient preference, precisely for patients who have either careers or hobbies that put them at high risk of bleeding while on a blood thinner. So competitive skiers, rock climbers, carpenters fall into this category. And then there is the group where they just have a high enough risk of bleeding, i.e. a HAS-BLED score of greater than 3, in whom the benefits of anticoagulation may be actually outweighed by the risks, simply by risk as opposed to by history. There are a number of other devices coming through to market. The Onplatzer cardiac plug is FDA approved and is in use, although they've had a rocky time with rollout since approval last year. There's also the Lariat device, which is a suture-based therapy that I'll come back to in a second. But regarding the Onplatzer cardiac plug, there is a fair number of observational data, but no randomized trials supporting its utilization. It has a similar goal, but a slightly different design. It's got two discs that can move independently. Ideally, the outer disc provides a little bit better seal potentially compared with the Watchman device and may result in fewer leaks. This is one representative observational study, 1,000 patients in Europe and Canada, high rates of procedural success, low rates of systemic thromboembolism post-implant that is comparable to the effectiveness of either the Watchman device or oral anticoagulation based on their CHEDS 2-VAS score. The Lariat device, as I mentioned, is a completely different approach. It's a suture-based closure, which mimics a little bit what surgeons do with oversewing the left atrial appendage. What you do is you obtain epicardial and endocardial access. So you're in the pericardial space and you're in the left atrial appendage, and you create a rail essentially by attaching two magnets through the tip of the appendage. That rail can then be used to slide a suture device over the appendage and ideally clip it off at the origin and tighten down the suture and close ideally with no residual leak. It's never been tested in randomized trials. It was sort of approved through a back door as a suture-based device, not necessarily a suture-based device for the left atrial appendage. So it can be used. It's probably a niche product, best used only for patients who absolutely can't take anything. So really the target audience is patients who can't even tolerate aspirin because it doesn't require any anticoagulation except that used for the procedure itself. But the utilization, I think there've been about 400 Lariats reported in the registry. It's a very niche product. So, we're looking at different, now we're in sort of like the iterations of how we approach our devices, and that's what the next series of studies will come out looking at. So in this case, the ASAP2 was looking at stroke and embolism, looking at different different approaches to anticoagulation, in this case, DAPT, as opposed to DOAC therapy or warfarin therapy. The biggest iteration, though, most relevant to our clinical practice, has been the second generation device. So the Watchman FLX or FLEX device really addressed some of the residual safety concerns from the original device. So this was the this is the Watchman 2.5 device. So it had a single set of barbs or anchors and had sort of these feet that bent inwards once released, but sort of were outward facing on the initial deployment. And the thought was that this was actually the source of much of the trauma to the left atrial appendage and the resulting pericardial effusions and tamponade that we had seen. So to address this, what they did was they basically took these feet and they welded them together to a central puck that makes this a much less traumatic device or potentially traumatic device. They also added a second row of anchors to mitigate any concern about risk of embolization. So the net effect of that, and we'll put that over in the right-hand corner here, is that when you're deploying this device, instead of having a spear, you actually have a ball. And we call that the flex ball, which we form before we actually push the device all the way into the appendage. And that is really seemingly effective at reducing the risk of trauma and punctures within the device. And you can kind of see this in this picture, side-by-side comparison of what it looks like when you're deploying the Watchman 2.5 versus the Flex. So in this case, you've got a ball that's atraumatic, relatively flexible, and hard to cause trauma. And in the 2.5 device, you had these 5 or 6 individual spears, any one of which could get caught up within the left atrial appendage and cause trauma. So at the moment, the evidence for the Pinnacle Flex consists of a single prospective study without a treatment arm, just a historical 2.5 comparator group. And in this group, you saw relatively similar effectiveness in terms of the risk of ischemic and hemorrhagic stroke. But what you did see was a significantly lower risk of pericardial effusion requiring cardiac surgery, albeit it didn't exclude the risk of pericardial effusion at all. So Seemingly effective, again, low risk of ischemic death, ischemic stroke, all-cause death, or embolism, and similar safety profile or improved safety profile compared with a 2.5 device. So just as a teaser, Jim Freeman, Matt Price, and our group have submitted a Latebreaker and had accepted a Latebreaker at HRS that's going to compare in the registry the 2.5 with the Flex, and the results are quite interesting. So I'm going to switch, and then the last few minutes of this talk, I'm going to talk a little bit about sort of what we've been able to do with the left atrial appendage occlusion registry. As I mentioned, the Watchman was approved in early 2015. The registry was launched in December 2015. It's been interesting to be part of that experience of developing in conjunction with key stakeholders of industry, FDA, and CMS to exactly how we're going to use these types of prospective registry to monitor the safety and effectiveness of devices as they come to market. Participation in the registry is a requirement for CMS reimbursement, and it serves as the backbone of post-market FDA surveillance for Watchman, and probably now in the near future for the Plutzer cardiac plug. We were really fortunate in that being the primary and only designated data analytics center for the LAO registry put us in a really strong position to submit a grant to enhance the research output from the registry. So there's synergy there where Jim and I put in a grant and got it funded by NHLBI to study the effectiveness and safety of this device in clinical practice. And that the benefit to the ACC is that they then had to invest less money in the actual registry, but still would be able to get the scientific output that they were looking for. So in this case, the specific aims are really comparing real-world data with randomized clinical trials to refine risk prediction to inform shared decision-making, and for some potential for comparative effectiveness research. And I use one example that I'll show you here is comparing the outcomes associated with different strategies of post-procedural anticoagulation. So in terms of what we've seen in the registry, and this is older data, but published in JACC 2 years ago, we had a relatively brisk uptake of the number of procedures cumulatively in the registry, and this curve is only accelerated. So I think we're now up to about 50 to 60,000 implants over 100,000 implants in the United States. The number of hospitals participating in the registry, initially we thought it was going to plateau at around 400, 500, and then it's gone up. I think we're up to about 650 implanting hospitals at this point, with a large number of implanting physicians, greater than 1,400 as of 2018. I think we're now up above 2,500 implanting physicians. I'm not going to spend a lot of time on this slide, but when you compare the characteristics of the patients in the US registry experience with the randomized trials, the thing that's striking is that they're quite a bit older, and that they are a little bit more representative of the overall composition of the United States, albeit underrepresented minorities typically are not getting these procedures in large numbers. And so understanding the reasons behind that remains an interesting future source of research. In terms of the clinical characteristics, most patients had a chance to TUS score of 4 and greater. Most had a Hasbled score of 3 or greater, so really reflecting a high risk of both bleeding and thromboembolic risk associated with the device. The annual volume, pleased to say that we're pretty far over to the right on this at our program that we built locally. That we're performing fewer than 1 Watchman implant a week. Acute procedural successes, in this case for the registry over here on the right, 98.3% is what we were seeing, which is comparable to what had been seen throughout most of the observational studies, and a little bit higher than what has seen in the original randomized trial. For major in-hospital adverse events, complication rate total was reported 2.16%. We realized that there was an error that we've corrected that's a little bit higher than that. So it's about 2.5% with the Watchman 2.5. The majority of these are major bleeding and pericardial effusion, which I don't have that on the slide. where it's cut off here. So I apologize for that. But we're still seeing about a 0.8% risk of pericardial effusion requiring intervention. So what can we do in terms of anticoagulation strategies? So this is, or looking at anticoagulation strategies and the associated outcomes. This is a study that Jim and I did that was presented at ACC last year. I can see that there are a great degree of heterogeneity in terms of what these patients are being discharged on post-procedure. So we kind of took an even larger group of strategies and consolidated them into the 5 most common, which boiled down to warfarin and aspirin, warfarin only, DOAC and aspirin, DOAC only, or DAPT. And you can see that the most commonly used combination was that which was included in the clinical study, which was warfarin and aspirin, and that the least frequent was DAPT alone. And what we asked ourselves is, can we use this natural variation to assess the effectiveness of these strategies in terms of outcomes to 6-month post-procedure? So this is a very busy slide, and I apologize for it. I should probably have a better figure. But let's take any adverse event in this population. What we did was we compared to warfarin and aspirin all of the other groups, and there were really 2 groups that stuck out as having statistically significantly better events, better outcomes compared with warfarin and aspirin. And basically it was the elimination of the aspirin seemed to reduce the risk of bleeding complications without a concomitant increase in the risk of thromboembolic events. So eliminating aspirin seemed to be helpful. And that held up at least for warfarin alone versus warfarin plus aspirin for major adverse events, and really didn't see any difference in readmissions or thromboembolic events of stroke or TIAs. So this has actually informed our practice as well as the design of clinical trials going forward. So I think it's a good utilization of this type of data where you can maybe understand, without conducting randomized trials or in anticipation of randomized trials, look at different strategies and try to improve care for our patients. I'm not going to spend a lot of time looking at the registry compared with randomized trials, other than to say that again, it's really hard to compare these two because the population of patients getting left atrial appendage occlusion in the United States are so much higher risk of all outcomes compared with the patients who had been enrolled in the randomized trials. So it's a little bit like handling or comparing apples and oranges. And so it's probably not that good approach. And we thought it was going to be interesting, but it was less interesting than we thought because the 2 groups are fundamentally not comparable. One of the things we've been working on recently is what's the experience of device embolization. Again, that's where the device falls out of the left atrial appendage or doesn't stay in there. It can happen both immediately or it can happen after hospital discharge. It is a rare but potentially life-threatening complication. So just from a clinical perspective, some hard-learned experience locally, we have had 1 device embolized that had to go to surgery. But what you want to do is you want to maintain access within the left atrial appendage. And what we do now is we actually wait a minute or 2 after we release the device to make sure that it's going to stay stable and it's not starting to shift. Because once you lose access in the left atrium, it makes it harder to retrieve the device before it might embolize. And devices are really actually quite likely to embolize. Any size device can probably get through the mitral valve. But the smaller devices, the 21s and 24s, can actually get pretty easily through the aortic valve into the systemic circulation. And I think in national experience, most of them have gone distally into the lower extremities, but a few have actually gotten wedged into the great vessels and caused problems. So it's really important to have some training experience to know what you're going to do, right? So you want to maintain your access. You want to have your go bag ready, which means that you've got a 20 French sheath with a Raptor snare, which is really the only snare that's going to be capable of capturing this device and getting it back into a large sheath. And that's great if you can do it, but you also need to have CT surgery backup immediately. So when this happened to us, we go through an immediate panic, but really very quickly we were able to get CT surgery mobilized. We had access within the left atrial appendage, and we're trying to sort of pin the device up against the wall of the left atrium. to sort of keep it in place, ideally to allow us then to get the Raptor snare up. However, it kind of escaped us and went into it was a large device, a 35 millimeter device, went through the mitral valve and sort of wedged itself into the apex of the left ventricle, where the patient immediately went into VT. But we were able to resuscitate them very quickly, got them to surgery, and Roland Dassi removed it successfully. Then put an atrial clip across the left atrial appendage. So the patient ultimately did well and did not need anticoagulation afterwards, but it's certainly not an experience that we would like to repeat again. But we're ready if it does happen. In the national experience within the registry, there have been 84 cases of device embolization. There were a couple of things that were associated with increased risk of embolization. That's having the device be undercompressed. The first generation device was higher risk, and lower volume centers as a whole has had a slightly increased risk of embolization compared with higher volume centers. About half of patients required surgical intervention. We suspect that a significant portion of those who didn't have surgical intervention or percutaneous retrieval probably died before, and the overall mortality of this cohort who have embolization is quite high at 17%. So best avoided, best to make sure you pay really close attention to those past criteria that I went over earlier in the talk, and that you're not really cutting any corners on any of that. You really want to be 100% sure that the device is going to stay in place. And then finally, I just wanted to show some science that was presented at ACC, basically looking at what happens if you do have a leak. And again, as I mentioned before, the majority of our patients have no leak. 73% have no leak, but about a quarter have some leak. And per the FDA approval, we accept small leaks of greater than 0 to 5 millimeters. We try not to leave behind large leaks, albeit sometimes the device shifts after you release it in a way that tilts and provides a little bit larger leak. So in this case, we were comparing what are the longer term outcomes of patients with no, small, or large leaks. You can see that overall the outcomes were pretty much comparable. The KM curves really weren't separating dramatically, but there was a difference such that surprised us, is that we sort of had assumed that the small leaks were actually ignorable. And what we found is that because there are a lot of them compared with the large leaks, that there is a significant higher risk of adverse outcomes, particularly thromboembolic events, in those patients with small residual leaks. And we would have thought that that was trivial, those were ignorable. But this finding has at least informed our local practice that we're spending a lot of time trying to eliminate it and go with 0 leak as opposed to accepting a small leak. So we'll try different devices, different angulations, do more recaptures, trying to get a perfect implant. And I'm going to finish on time by one more plea about the Champion AF trial. So we've been enrolling patients in this trial for a little bit over a year now, and really need to enhance our enrollment. I think we've got 10 patients that we've randomized, and it's a 1-to-1 randomization of Watchman FLX device compared with DOAC therapy in patients with really no contraindications or no reason why to think that they couldn't take long-term anticoagulation. So these patients are all around us, right? There are at least 60,000 patients who were discharged from Haven Hospital who fit this profile in 1 year. But we're having a really hard time getting them to be seen by our research clinic. And I kind of would ask all of you guys to think through your patients as you're seeing patients with atrial fibrillation, even if they're doing well on DOAC therapy, to at least think about whether or not they would be a good candidate or would be interested in this trial. So we're randomizing them to Watchman versus continued DOAC therapy. The follow-up period is about 5 years. And for patients for commercial implants, this is really their only access to left atrial appendage occlusion at this time, at least if you're going to stay within the clinical guidelines and not put you and your institution at risk. So we'll be following them for 5 years. It's really not an inferiority study, trying to demonstrate whether or not this is a niche device or whether or not this is a strategy that should be sort of mainline for all patients with atrial fibrillation at risk of thromboembolic stroke. So in conclusion, among AF patients at risk of stroke, antithrombotic therapies remain 100% the standard of care at this moment in time. Hopefully the CHAMPION study will show whether or not that's the right thing or whether we need to evolve our thinking. A significant proportion, at least 40% of eligible patients are not on appropriate therapy for stroke reduction. And amongst those patients who can't or won't take anticoagulant, left atrial appendage using a Watchman device probably is a reasonable alternative. The current clinical guidelines updated in 2019, I think, or maybe 2018, said it's a reasonable alternative, but the level of evidence was to be, or the recommendation was a 2B with a level of evidence of C, I think. So really very soft recommendation from the clinical guidelines. But I think, if you think about those patients who can't take anticoagulant, we really need to be doing a better job of screening, identifying, and seeing those patients. So I'll stop there. There are a couple of chat questions that I can look at. And if anybody has any other questions that they want to say, I'd be happy to talk. So Amar, let's see.
So Jeptha, if I may, and that ties in precisely to Amar's question that's in the chat box. The study, the registry data that you just showed that was presented at ACC about 10 days ago by Dr. Al-Khoury, it did show, as you said, that there's about a 25% residual leak, right? Now, he also commented that conferred about a 10 to 15% relative risk increase in events. So how do you handle, and this ties into Amar's question, how do you handle those residual leaks? And if the CHADS VAS score is relatively low to begin with, is it really important to go after a leak if it is small?
So our approach to this has been, there certainly is risk associated with it, but there's probably greater risk of repeat procedures. And so the thing that it should impact, the thing that these findings should lead us to do is to take greater care with the initial implant rather than try to recover after a leak has formed or if a leak persists. So what can you do when you have a leak? So you have two things you can do. You can maintain on anticoagulation, right? And that's what we have done for patients with a big leak who can take anticoagulation well. We've simply continued it. But in those patients, or we had one patient who had a large leak who couldn't take anticoagulant. I think they had a greater than 8mm leak. And in that patient, we, in combination with Jeremy Asnes, used an Embolization device to kind of, not the cardiac plug, but one of the smaller vascular plugs to kind of seal off the leak. It was a hairy procedure, I'll say, and that, the left atrial appendage is a very fragile piece of tissue, and it's really easy to perforate. So I think the wrong lesson from Al-Khoury's findings would be like, okay, we got to stamp out leaks once they're there. The right lesson is those leaks, we should take care to minimize the risk of those leaks being there at all. The other question from John, talking about the EPIC alerts. So, we spent a lot of time in I think 2019 developing a best practice alert for patients with atrial fibrillation who weren't on anticoagulation. And the way the alert would fire was that if your CHADS2 VAS score as calculated through EHR was greater than or equal to 2, and there was no warfarin or DOAC in your med history, that it would come up. And it would recommend anticoagulation and lead you directly to that order set. And then it would also, if would note the availability of referral to Fortunately, we had like the first 3 or 4 months, we had the attention of the care redesign team, and that disappeared as soon as COVID came through. So we really haven't seen the dashboard effect of that. I do see it firing in the background, so I know that it is there, and that some of you may be seeing it when you are treating these patients. So I think it's been effective, but it's been hard for us simply because of resources to actually identify, have we moved the dime on this? And I don't think we have, because again, it's been really pushed to the side with COVID. I'm hoping that as we come out of COVID, that we can sort of re-engage the IT and care redesign teams on this. Because when you looked at our data, we were doing a little bit better than the national average in that 65% of Yale New Haven hospital patients were on DOAC or warfarin, and that compares favorably to the data that I showed earlier, but it's only about 50%. But that's still 35% of our patients who haven't had their brains protected against stroke, and I think there's still opportunity to improve that.
Are there any other questions from the group? And Jeptha, one last question, going back to the leak issue from Amar. If you continue DOAC in a small leak, would you ever re-image them to see if the leak might be closed later?
Yeah, so if you see it at 45 days, we oftentimes will repeat it at 6 months. I will say that hope is not a great strategy. Like, it almost never shows a difference between 45 days and 6 months, and you're just kind of left having to handle it. I think we in general have been treating patients who can't take oral anticoagulants. So if they have a leak, based on Al-Kuli's findings of the 0 to 5 and the small relative risk of increased risk of stroke associated with that, we haven't been keeping people on anticoagulant because these are people who really can't take it. So it really hasn't affected us, I don't think, on the back end.
Thank you very much. Any other comments or questions from the group? All right, Jeptha, thank you very much.
Thank you. Take care.